So fluids and sodium go hand in hand. It makes a lot of sense to talk about these together, and I'm going to explain to you a little bit about how fluid works in our body, how to give fluid, how to deal with hyper and hyponatraemia, and why saber-toothed tigers are really the cause of heart failure. Now let's start at the basics to ensure everyone is on the exact same page. Now once upon a time we belonged in the ocean, didn't need to worry about fluids because we lived in salty fluids, which was great. Now fluid doesn't care too much for barriers. So the barriers in our body, like between our cells and outside of them, or between blood vessels and outside of them, they're incomplete to different degrees. So we call these bits or chunks of our body compartments. And fluids, along with some of the salts in those fluids, they move between compartments in different ways, and we're going to talk about that in a second. Now Medicine 101 is keeping blood on the inside, okay? Or it has been since we decided leeches and bloodletting were a bad idea. Now, we like blood to stay where it belongs, being pumped around in arteries and veins and bathing tissues in oxygen and yummy nutrients. And our body can sense how much blood we have through a number of pressure receptors, which are called baroreceptors. Key points such as carotid sinuses, aortic arch, more on them later. So long ago we decided that we'd check out the land, and everything got a bit more complicated, because we needed to work out how do we keep all that wonderful salty water we so love on the inside. And this is where kidneys proved a helpful advantage, and one of the reasons we drink fluids, not booze. So what are these compartments that I speak of? Well, about 60% of a male is fluid, slightly less so in a woman due to different body composition. And of that 60%, about 2/3 are inside in cells. So I'm just changing from fractions to percentages here just to mess with you a bit. Fantastic. So compartment 2 is unsurprisingly called the extracellular fluid, which is outside of cells. Of that 1/3 of extracellular fluid, about 80% is interstitial, and that's what our tissues are bathed in themselves. And about 20% is actually our blood, our plasma. So if we put some numbers on that, taking the increasingly rare textbook 70 kilogram average man, you have about 2.8 litres of blood in the average man, or if you want to break away from the brainwashing of the patriarchy, it's about 2.4 litres of blood in the average woman. This is a big deal because if you give somebody pure water, it will wash around and reach a nice equilibrium. So if you cut yourself making fancy cocktails, drunkenly showing off at a party and bleed a litre of blood onto the floor, I run over and try and replace it with a litre of pure water IV, it will divide out accordingly. So 1/3 will end up in the ECF and only about 20% of that will be in the blood, which is 66 mils. Bit disappointing considering I gave you a litre intravenously, so if your intention is to replace the blood on your horrified friend's carpet, you failed spectacularly. So that's fluids. Now what's this osmolality I keep hearing about? Well, recalling that osmolality is just how much stuff is dissolved in a litre of fluid. Osmolarity, with an R, is the same, but dissolved into a kilogram of fluid, not a litre. And as far as I can tell, the main reason there are two different measurements is to catch out medical students. And recalling then that the universe is unbelievably lazy and hates gradients of any description, and it wants everything to be the same, nice, flat, and level. Thus, freely moving water will shift about, so the osmolality will equilibrate out if it can between the compartments. So if I magically add salt directly into your blood like a fast food Harry Potter, the salt will shift, if possible, into the interstitial compartments. But it really just gets stuck then, because it can't make it into the cells. The water itself is going to have to shift about to balance out the osmolality. Remember this when you consider what normal saline does when administered IV. 286 milliosmoles per litre is roughly your body's osmolarity, and it is the same distributed across almost all of your fluids. Not quite all. There are some notable exceptions that you can look up in your own time. But all the ones that you care about are isoosmotic. What happens if you add some salt? It increases the osmolality, it increases your thirst in your brain, and the increased thirst means you drink more water, which dilutes it down back to normal. As a result, you're going to get a pressure natriuresis in your kidneys, where you have the increased volume and hydrostatic pressure forcing the fluid into the tubules. It's going to drag you back down towards normal. This is called homeostasis, and it's kind of the reason we're not all dead. What do you need to know about fluids on the wards? Well, very, very simple. You need it to live, and if your patients can't take it for themselves, you need to be the person that gives them some fluids. You will be amazed, even though it sounds basic, and this is overlooked. The requirements can be described per kilogram. As you see here, it's about 30 mils per kilogram. You need about 1 millimole per kilogram of sodium, potassium and chloride, and a little bit of glucose. If you're like me and you want some sort of cognitive shortcut here, a 70 kilogram male is going to be 2 liters of water, 70 of all the salts, and a liter of 5% glucose. That will do the trick. If they're heavier or lighter, just bump it up accordingly. It's a bit of an inexact science, and realistically they're likely to be taking something in the form of food unless they're completely nil by mouth. If you were to look at the common fluids that we prescribe on the wards, you'll notice that normal saline is, of course, not normal. It is hyperosmolar slightly with an osmolality of 306 and is packed full of chloride, which is far, far higher than the chloride in your plasma or serum. Hartmann's, Plasma-Lyte and other balanced inverted commas solutions are somewhat more physiological in their composition, and they tend to be a bit more isoosmolar as well. So now you've nailed the basics, believe it or not, of fluid physiology. If you can appreciate that we're fleshy, leaky sacs of water and that the ideal situation is blood on the inside, to bring some additional nuance to your understanding, if you can appreciate that our body is made of fluid compartments and fluids will distribute according to the size of the compartment where possible, and that osmolality is going to drive water across membranes to equilibrate things, you are pretty much equipped with all the basics to work out everything else if you can appreciate those things. Nailed. What are the consequences of getting this wrong? If you have a patient in hypovolemic shock, we only have 5% dextrose or glucose, depending on what country you're in, to hand. Well, how much do you need to give to restore circulating volume? Let's say he's got 20% hemorrhage. In a 70 kilogram man, we can expect about 5 litres of blood. A 20% hemorrhage then means about 1 litre needs to be replaced. And just like in our cocktail example, which definitely was not autobiographical, dextrose will not work here, because if you consider the fractions and percentages of the fluid compartments that we've just described, and I will show again in a second, only about 1/12 of the water given IV is going to stay there if it doesn't have any salt with it, which will keep it within the blood vessels. That means to replace 1 litre of intravascular space, you would have to give 12 litres of dextrose. That's not ideal for a number of reasons. To visualize that with our typical 70 kilogram male, the glucose is going to be distributed in this entire compartment across all of his body fluids, because there is no salt in there that's going to force it to stay within the vessels. It is just going to slosh around pathetically. So 20% of a third is what's going to end up in that plasma. In contrast, when you give the crystalloid, the additional salt is not going to be able to enter the intracellular compartment, so it's going to stay extracellularly. What that means is that the water that you introduce alongside that salt needs to stay with it to maintain the osmolality. Because of that, you've bounded to that 1/3 of extracellular space, which means now a much higher percentage of the litre overall ends up in the plasma. That's why we don't resuscitate with 5% glucose. Let's talk about dysnatremias, that is to say hyper and hyponatraemia. Now it's best to think about these not as a problem of salt, but to think about these as a problem in the relationship between salt and water, because it's very rare that you have too much or too little salt. It's always to do with the ratio and proportions. Let's start with hypernatremia because it's so much simpler. The first thing you need to know is that it's very, very rare for hypernatremia to be caused by just having too much salt. Much more commonly, it's a lack, relatively speaking, of water. As with everything in medicine, you can start to break these down into baskets to help you conceptualize what's going on, and I always recommend doing this. So you could, of course, have an increased intake. That would often be iatrogenic if it happens at all. Perhaps someone was administering hypertonic saline. If you had a very, very high sodium in your diastolate during dialysis, it could theoretically happen. Or if someone literally ingested a packet of salt. So it can theoretically be possible. Much more common is hypodipsia, so not drinking enough. This is really important to remember as a generalist on any of the wards, because Often you're going to be looking after vulnerable patients, elderly, delirious patients, perhaps patients with mental or psychiatric illnesses. And these things will possibly blunt their ability to feel thirst, or potentially blunt their ability to actually act on feeling thirsty. So if you have a patient who is perhaps demented or incapacitated physically in the bed, they're not going to be able to reach for a jug of water or ask for their empty jug to be refilled when they're feeling thirsty, even if they do have a thirst mechanism that's working, and often it's not working in these people. It's up to us to be alert to that. Primary hypodipsia, so just not drinking enough from an organic pathology, is pretty rare, and it would include things like tumours with hypothalamus, third ventricle, maybe granulomatous or infiltrative diseases, like sarcoid or vasculitis, infections, perhaps TB, things like that. The third category to consider is losing too much water, and broadly that can be from your kidneys. When you lose too much water in your kidneys, we call that diabetes insipidus often. The secret to diabetes insipidus, by the way, is of course in the name. Back when we used to drink urine from people who peed too much, the people with diabetes mellitus had sweet tasting urine. The people with diabetes insipidus just peed too much water. It was a bit insipid. It was not very nice. Tubular dysfunction, in a sort of inverted commas here as a broad category of dysfunction, can of course lead to failure to reabsorb water and to lose too much when you need to. Osmotic diuresis, if you have a molecule in there, perhaps mannitol or something, or in the case of the SGLT2I inhibitors, glucose, which can drag water with it down the tubule and dehydrate you. And very rarely reset osmostats, where you have changed your internal... I skipped a reset osmostat. In terms of non-renal functions, fever, burns, diarrheal losses, perhaps. As ever, a good history and exam should do the trick nicely. Now remember, in medicine, you can always phone a friend for those fancy causes of hypernatremia. As a generalist on the wards, you really simply need to be alert to the elderly and the debilitated. It isn't that rare. If you do encounter hyponatremia, don't rush the correction. They're going to be okay if you just take your time. So don't correct too fast, because that could induce cerebral edema, and I'll explain why in a second. There is a speed limit per litre. It's 0.5 millimoles, but about 10 millimoles per litre a day is grand. It is associated with worse outcomes, and it's not entirely clear whether that is because of the precipitating causes, for example being elderly and delirious in hospital, or whether it's the hyponatremia itself. And this is also the case, I think, in a lot of the hyponatremia observational data. It's generally associated with worse outcomes, but actually disentangling the effect of the underlying disease from the process of the hyponatremia itself can be challenging. It's often avoidable on the wards. If it's happening to your patients, you're missing a trick. So good, thorough clinical care, nailing the basics, will help you avoid a lot of your hyponatremia. Consider the case of the nursing home resident, delirious with a sodium of 160, happens to look like a male model. We'll ignore that for now. They've aged incredibly well. Well, there is actually a calculator, and most calculators in nephrology and medicine are a bit rubbish, but this I've often found to be really useful, and it's the free water deficit. Aiming for a sodium of 140 will tell you they're 5 litres behind. This is very useful. Now, we've already established that we're not just going to drop 5 litres into them, because that will correct them instantly. Instead, let's take our time and slow down a little bit. So he needs 5 litres extra, plus he's going to need his daily requirements, and we've already said that's about 2 litres. There's no major rush. Why don't we bring him down over the next 72 hours? That's going to be 11 litres, isn't it? Those 5 can be pure water, but the maintenance, of course, is going to need the salts and a little bit of glucose themselves. And what I'll probably do here is give this guy 2 litres of half normal saline and perhaps 1.5 litres of 5% over the next 3-4 days. You can check it every day. Remember, you could do this faster if you wanted. Technically, we could do this over 48 hours and still be within our speed limit, but you don't get a prize for doing it quickly. It's very unlikely to help them, and you're running the risk of making it a bit more difficult and dangerous for them. So why do it? Okay, so let's discuss hyponatremia, which is common and a very, very interesting situation. The best way as ever to conceptualize it is that there's a mismatch between sodium and water. Now, the entire crux of hyponatremia, the main thing you need to understand hyponatremia, the key to unlocking the entire pathophysiology is 3 letters, ADH. If you understand ADH, you understand hyponatremia. ADH is anti-diuretic hormone. The secret here is in the name. Diuretics, they make you pee. This is anti-diuretic, so it's the opposite. It makes you do less pee. Sometimes it's called AVP, the V standing for vasopressin, but I actually really prefer ADH because it's descriptive clinically and it's immediately obvious what it does in the name. Vasopressin doesn't have that same face validity to it, does it? Now, how does it work? Well, let's keep it really, really simple. It activates the V2 receptor on your epithelial cells in the collecting duct that's in your kidney, in your tubule. And these are the ones towards the end that are responsible for sucking the water out of your urine back into your body. This is what stops you peeing out pure water and just dying. And if you really cared, or if you're studying for an exam, it's a G-coupled protein, activates adenyl cyclase and causes the production of cyclic adenosine monophosphate, activate protein kinase A, but really, who cares? I certainly don't. What I do care about is that this binding, it leads to this big exocytosis of vesicles containing aquaporin water channels. And what you do is you punch these aquaporin channels into the tubule, in comes the water, back into your body where you want it. Hooray. Now, the European Renal and Endocrine Society released joint guidelines on hyponatremia a few years ago in 2014, and I swear to God it's actually really good and well worth a read. The link is going to be in the description. This and a few of the following images are taken from it. And essentially what this initially complicated graph is showing is that as your osmolality in your plasma rises, that's on the far left, well then you release more ADH. Simple. Here they're called the ABP, of course, because they're contrarian. And as a result, you retain water because you don't want to be too concentrated. You need some water to dilute it back down. Simple. And as you do that, in turn, your urine concentration increases. Nothing to it. How does that explain why a saber-toothed tiger can cause heart failure? Well, remember the good old days when you were running around hunting and gathering on the savannah in your loincloth? When times were simpler, there was no TikTok and Facebook. It's just you and your spear and your life expectancy of 21. Imagine you're attacked and bitten by a saber-toothed tiger. Now, as your precious blood is thrown around the savannah, what happens to your body? You're going to lose cardiac output very quickly because your heart needs blood. We've established that as a core fundamental. You need blood to live. And what's going to happen is that your body is designed to notice when your blood pressure drops because it's really, really important. And it's going to take steps to reverse that. And when your baroreceptors in your carotid body, your aortic arch, detect that drop in pressure, the loss of cardiac output, they're going to go into overdrive. They're going to release renin. They're going to release angiotensin 2. There's going to be sympathetic outpouring, isn't there? And you're going to vasoconstrict to drive up your pressure. You're going to release tons of ADH and aldosterone. This is going to have 2 effects. One of them is that you're going to retain as much salt as you can in your kidneys because salt is osmolarity, it's volume, is water, it's all connected. You're going to drag it back in where you can to try and keep your blood pressure up. And you're going to retain all your water. There's ADH smack bang in the middle of all of this. Both of these are important in maintaining blood pressure. And what you hope will happen is that you're going to pick yourself up, kick the tiger away and flee, live to probably die of a tooth infection shortly thereafter, because that's what they all died of, I believe. This is important because what will often happen is that preferentially you're likely to retain more water than you are salt, and actually as you limp back to your cave you may become hyponatremic over the next number of days because you've retained much more water proportionally than you perhaps need to maintain your osmolality. So you might be hyponatremic, caveman, but honestly, who cares? Because while it's not particularly great to be hyponatremic, it's definitely awful to be hypovolemic and not to be perfusing your organs. If you can't perfuse your muscles and your organs, you die of hypoxia and acidosis, remembering that your muscles are your main short-term acid buffer. So this is clearly our priority. Your main priority is to perfuse enough to escape your tiger. This whole osmolality and hyponatremia business is for nerds. Who cares? Your job is to get out of there. This system of priorities where you much prefer volume over osmolarity works perfectly well in the savannah. It makes total sense. If you open a textbook, what you'll often find is they say that your body defends volume over osmolarity, which is a kind of old school cool way of saying that. It works well, and all was well until the only thing we had to hunt for was our wallets in McDonald's, and the only thing we gathered were coronary plaques. This changes everything. So what happens when your tiger is actually a lifetime of fast food and comfy chairs? Well, your body doesn't know what a Big Mac is, and your cardiac function, as it begins to wobble, your body's just going to notice those same changes in output and in the pressure receptors as if it was bitten by a tiger. And the same response will happen, only this time, instead of boosting blood pressure and volume to keep you alive, the boost is making things worse. Okay, the increased preload, increased afterload, increased work of beating. The hyponatraemia is probably going to affect myocyte function. This is exactly not what your heart wants to deal with right now, and a vicious cycle begins. As this continues, you get this continual activation of ADH that leads to overaccumulation of water relative to sodium, and that's why you get hyponatremia in heart failure. Now throw in diuretics, which work by removing sodium from your urine, and perhaps a poor diet, maybe a few litres of Coke or something to spice it up, and you can really sink into a quagmire of hyponatremia here. So hyponatremia all comes back to ADH. Some causes of ADH release, well, post-operatively you can often see little wobbles in sodium. Patients can become hyponatremic. Polydipsia, intense exercise, marathon runners for example, clubbing, MDMA, cyclophosphamide and so on, all can release ADH, somewhat appropriately, somewhat inappropriately. There are a long list of drugs which I'm not going to read for you, which can cause ADH release also. I see at the bottom a mention of SIADH, the syndrome of inappropriate secretion of ADH. I think it's a little bit of a psychological trap to even have that in your vocabulary, because the more you consider and think about it, you're almost always going to find a reason from these lists and others as to why they may have released ADH. Often I find it can be a little bit of a cop-out when people fail to really generate a good story or reason. So after a few normal tests, maybe some TFTs, even though hyponatremia is very rarely caused by hypothyroidism, maybe stopping some diuretics. When the hyponatremia persists, people throw their hands in the air and claim SIADH, but while it surely does exist, I suspect it's a lot more rare than people think, and actually a lot of diagnostic failure or diagnostic difficulties are short-circuited by a label of SIADH. Now, the European guidelines have a wonderful flowchart that really simplifies down the diagnostic algorithm. So, very simply, from the top, the first thing you do is check whether or not your hyponatremia is real or not. Is it fake? To do that, just check an osmolarity. If it is low, then it's real. Simple. If it's not low, you're then thinking of things like, well, is this a laboratory artifact, a pseudohyponatreamia, which I'll talk about in a minute. Next, are they dying? Are they seizing? Are they in a coma? If they are, you need to get rid of this algorithm and go fix your patient, and I will touch on that in a minute. If they're not dying, and you have the luxury of a cup of coffee and you can have a think about what you would like to do, there are two tests that you can order. The first is not very good, and that is urine osmolality. In my opinion, it is somewhat limited. If your urine osmolality is low, you can claim that they're peeing out pure water, but the causes of that, primary polydipsia, beer podomania, you'll often get them from the history anyway, and you shouldn't have needed this test. The second test in the algorithm, urinary sodium, is actually really useful. The simple way to conceptualize it is, if your urinary sodium is low, it means your kidney is reabsorbing it all. Think back to your tiger. You are releasing your renin and aldosterone, you're sucking back all of your sodium. You're trying to maintain a blood volume for some reason. This can really help conceptualize what's happening in the body. Well, have they heart failure, liver failure? Are they actually ECF reduced? Could they be having bad diarrhea, vomiting and so on? If that's not the case, it leads you down a completely different set of differentials. So it's a very useful test, I think. You will be aware that there are some risks associated with too rapid a correction of hyponatremia. Why is that? in a normal brain, you do, of course, have a normal osmolality, which is generated by the osmoles within there, be they salts, proteins, etc. In the state of hyponatraemia, you become hypotonic because sodium is one of the main drivers of the osmolality. If you lose sodium, instead of being 286, you will drift down a little bit. What this means is that you now have more osmolality inside in your cells than you do on the outside. So the water is going to flow into the cell a little bit. It's going to swell slightly as the osmolality comes down and they equilibrate. Your cells don't like this, so what they're going to do is, in the short term, they're going to adapt by removing sodium, potassium. They're going to drop the osmolality, the water requirement, so to speak, inside in there to let water leave again, and the cell will no longer be quite as swollen. And then over time, some of the more organic, proteinaceous type of osmoles, it takes longer to get rid of them, but it will do so. So eventually, the water will balance out, it will leave the cell again, all is well. The problem now, of course, is that in terms of the total amount of osmolytes inside in your cell, you have much less than a normal brain. So, if I then rapidly correct your sodium, and you've gone from 110 back up to 140, suddenly inside in your brain has nowhere near enough osmolytes. And outside in your serum, you now have tons of osmolytes because I've pumped them into you with my hypertonic saline. What's going to happen? The water is going to need to equilibrate and try and normalize those two things. It's going to leave the cell and flow into the serum to try and drag down the osmolality, and your cell is going to rapidly dehydrate. This is what leads to osmotic demyelination. You can imagine that if you were to do this much more slowly, the process which led you to having these lower osmolytes would of course reverse. Osmotic demyelination is thankfully rare, but is catastrophic were it to happen. I think people are quite rightly scared of it, and it's easy to avoid if you just take your time. Risk factors are going to include elderly, immunosuppressed, poor nutrition, and alcoholism, I think, has been linked to it as well. So what are you going to do if they're seizing? Well, again, from that guideline, really simple. Don't worry about formula. Don't worry about thinking too much. Grab 150 ml of hypertonic saline and just drop it in over 20 minutes. It's much, much simpler than you think. And then what do? You check. Checking results regularly in medicine is basically cheating, because you've updated data, you remove all the uncertainty, all the guesswork. You don't need to make any predictions, so your work is dramatically safer. You're just reacting. So you check and you see where you are. Your goal is 5. 5 is a magic number. Conveniently, your 24-hour speed limit is 10. Double that. And that's it. So you just keep checking until you've hit those targets. Assuming they are now neurologically stable and stopped seizing, now the fun can begin and you can work out the diagnosis. If they're not stable, now is probably the time to actually call for help and reconsider the diagnosis here. And perhaps the sodium is not the cause or the only cause of the seizure. Remember, the big red button for an intractable seizure is sedation in ITU, so if nothing is obvious or fixable, you need them for backup as you work through scans, lumbar punctures, all of that jazz. If the sodium is rising too fast, you should probably call for a bit of help, perhaps from nephrology. We can add back in water, or perhaps even block aquaporin 2 with a Vaptan. It's a little bit beyond the scope of what we're doing here, but I can do another video if you want about that. So what's pseudohyponatreamia about? I mentioned that. Well, it's a laboratory artifact, is the first thing you need to know. And it occurs when abnormally high concentrations of lipids or proteins in the blood interfere with measuring sodium. What might cause that? Perhaps hematological malignancies, something with tons and tons of antibodies. Now, allegedly, pseudohyponatreamia was more common back in the day when we used flame photometry to measure serum sodium, as compared to now when we use fancy ion selective electrodes. But despite some claiming it's historical, it still occurs because at some point all venous blood samples need to be diluted, and there's a constant distribution between water and the solid phase in the assumptions here. What do I mean by that? Well, look at the two vials in the middle. On the left you have normal blood, so you have a normal proportion of solid to water phase. On the right you've got way too much solid phase. Perhaps these are the antibodies that we were talking about, or perhaps these are lipids in a hyperlipidemia. But what's going to happen is that in the lab, they're going to take a sample of that, they're going to squirt it into a tube, and then they're going to top it up to 2 mils perhaps. And they're going to top it up with whatever they need to top it up to get it up to 2 mils. And they're going to assume that whatever they put in there, 20% or whatever it is, was solid phase. And that assumption is where they go wrong. The trick here is to measure your serum osmolality in an undiluted sample, and the result should be normal in pseudohyponatreamia. If the measurement of osmolality isn't available, well, just go to a blood gas machine and pop it in there, because the blood gas analyzer gives you a true sodium concentration because it uses an ion selective electrode. And of course, it's undiluted. Now you know about pseudohyponatreamia. Unfortunately, this is not fantastic dinner party chat, but it's really impressive if you can pull it out of the bag every so often. So when you're giving fluids or taking fluids, you just simply need to consider the following questions. What is my intention, and what is this going to do to intravascular volume? A secondary concern, what will this do to sodium? And if you can answer those questions, you then have to take a step back and say, is that really what I wanted to do? Now, there's been an interest in comparing normal saline to balanced crystalloid solutions, plasmolite, Hartmann's, and so on. To summarize the literature, really, things lean in favor of balanced, but it's not particularly compelling, particularly in ITU or in A&E, in high volume settings where you may be getting a lot of resuscitation fluids. There's probably more of an advantage at that point, but you're certainly not going to get in trouble or run afoul of anything if on the wards you give someone a litre of saline instead of a litre of plasmolite. I think in situations where you are administering a lot, there probably is an increasing advantage to using balanced solutions, mainly I think because of the chloride load. The chloride introduces a hyperchloremic acidosis, and particularly post-op and in transplants, I think it can lead to a hyperkalemia. Okay, so I hope that was helpful. It was a quick overview and touch on a lot of various things. I'll leave some reading material in the comments and let me know if there's anything I can help you with. Cheers.